Welcome back to Master Oral Pathology. Today, we're unpacking a highly board-relevant topic that every single dental student needs to have completely locked down. We're looking at a specific subcutaneous fungal infection known as sporotrichosis. Look, as future clinicians, you're going to encounter a massive variety of oral lesions. And sure, most of the time an ulcer is just a traumatic ulcer or a simple aphthosore. But distinguishing a subtle chronic fungal infection from a lethal malignancy or maybe a complex autoimmune condition is an absolute clinical imperative. Because this specific organism absolutely loves to masquerade as other serious conditions. Misdiagnosing it can lead to some pretty severe consequences for your patient. So we're going to break down exactly what you need to know to confidently identify and manage this disease for your exams and, of course, your future clinical practice.
Okay, so let's get into it. Sporotrichosis is essentially a global opportunist. It's a widely distributed infection caused by the fungal organism Sporothrix shinkai. Now, in clinical vignettes and out in the real world, you're very often going to hear it referred to by its colloquial name, rose gardener's disease. And honestly, this name gives you a massive hint about who typically gets this and how it's transmitted. Just imagine the classic patient demographic sitting in your chair. Landscapers, florists, agricultural workers, or even just your everyday home gardening enthusiast. They're working outside, handling vegetation, and bam, they get pricked. You really want to cement that association in your mind right now. Whenever you see Sporothrix shinkai on a test, think of the outdoor worker and think of rose gardener's disease. To get this mentally mapped out, our agenda today is going to quickly cover etiology and pathogenesis, clinical features, histopathology and immunopathology, differential diagnosis, and finally, treatment and prognosis. All right, starting with number 1, etiology and pathogenesis, or the origin of the infection. So, the physical journey of this infection follows a very strict chronological path affecting the subcutaneous tissues. Step 1 is inoculation. This is where the skin or mucosa is directly punctured by contaminated soil or thorny plants, like rose bushes. The fungus literally hitches a ride on that thorn deep down into the subcutaneous layer. Then comes step 2, which is an incubation period lasting several weeks. Now, this incubation phase is absolutely crucial because it creates a diagnostic gap. Think about it. Several weeks can pass and the patient has completely forgotten about pruning their roses, right? When they finally present to you in the clinic, they aren't going to automatically volunteer the history of some minor scratch. Eventually, by step 3, the patient develops palpable subcutaneous nodules right at the site of inoculation. And finally, in step 4, those nodules frequently break down, necrose, and become ulcerated. Knowing this delayed timeline is exactly why your detailed medical and social history taking is absolutely vital. Moving on to section 2, clinical features, basically observing the damage. Now here is a classic board exam distinction that trips up a lot of dental students. You have to understand the drastic difference between the skin presentation and the oral presentation. On the skin, the lesions are actually relatively straightforward because they follow a visible roadmap. They appear at the inoculation site and classically spread right along the lymphatic channels of the arm or leg. They form these red nodules that subsequently break down and produce an exudate. But intraorally, it manifests completely differently. In the mouth, it typically presents simply as non-specific chronic ulcers. There's no obvious lymphatic tracking in the oral cavity to tip you off. It just sits there on the mucosa or palate as a solitary indurated ulcer that absolutely refuses to heal. This stark contrast is exactly why it is such a tricky condition to diagnose from just an intraoral exam alone. Another crucial point to keep in mind when evaluating these patients is the larger systemic picture. During your head and neck exam, you might actually detect regional lymphadenopathy. That means the draining lymph nodes near that oral ulcer could be swollen, tender, and palpable. However, true systemic involvement, where the fungus actually disseminates to internal organs or bones, is exceptionally rare. In fact, you should really only expect to see systemic spread if your patient is actively immunocompromised. So what does that look like clinically? Think of patients with uncontrolled diabetes, patients with HIV or AIDS, or maybe organ transplant recipients taking heavy daily immunosuppressants. For your healthy, immunocompetent patient who simply had a run-in with a rose thorn, the infection is going to stay tightly localized to the subcutaneous tissues and regional lymphatics.
Let's shift gears to section 3, histopathology and immunopathology, what it looks like under the microscope.
If you take a biopsy of that chronic oral ulcer and send it off to the pathology lab, the primary tissue response you're going to observe is granulomatous. Granulomatous inflammation is essentially a biological quarantine.
Your body recognizes that it can't immediately destroy this really tough fungal invader, so it sends in specialized macrophages to build a wall around it. Occasionally, you'll see central abscesses forming right in the necrotic middle of these granulomas. As for the organism itself, Sporothrix shinki appears relatively small and round to oval in shape, just scattered sparsely within the tissue sections. And honestly, because they're so small and sparse, they can be super difficult to spot on a standard H&E stain. Now, what is highly testable for your exams is what happens to the tissue sitting on top of the infection. The overlying epithelium often exhibits a wild reactive condition known as pseudoepitheliomatous hyperplasia, or PEH. Let's break that word down real quick. Pseudo means false, epitheliomatous means resembling an epithelioma or cancer, and hyperplasia means overgrowth. So the epithelium is growing rapidly downward into the connective tissue in these thick, jagged projections. Why does this matter to you as a clinician? Well, because PEH looks incredibly similar to well-differentiated squamous cell carcinoma under the microscope. If a pathologist, or if you, only looks superficially and misses those tiny fungal organisms and the deeper granulomas, you could easily misdiagnose a completely curable fungal infection as a malignant oral cancer. That is a catastrophic misdiagnosis, and it's a massive trap you absolutely need to be aware of.
That brings us to Section 4, differential diagnosis, how we definitively confirm the suspect.
I want you to pause and consider this for a second. If this infection mimics so many other granulomatous diseases, we're talking tuberculosis, tertiary syphilis, deep fungal infections, or even squamous cell carcinoma, how do we, as clinicians, definitively lock in our diagnosis of sporotrichosis? We really can't afford to guess here when the treatment protocols for all these diseases are so vastly different. We need absolute, definitive, hard evidence. The secret is knowing exactly which diagnostic test to order. First things first, avoid serological antibody testing. Testing a patient's blood for antibodies to S. shinki is notoriously unreliable for this specific organism, so please do not let a board question trick you into selecting it. Instead, your definitive gold standard is culturing the infected tissue on saburad agar. Saburad agar is that classic fungal culture medium you probably learned about back in microbiology. Its low pH inhibits bacteria while allowing fungi to thrive. By growing the organism, you get 100% confirmation. Alternatively, if you've already taken a biopsy sample, utilizing special silver stains on the tissue will highlight the fungal cell walls. This allows the pathologist to directly identify those small, round to oval organisms hiding out inside the granulomas.
Finally, Section 5, treatment and prognosis. Defeating the infection.
The pharmacological management of this disease has a very specific, almost old-school hallmark. Your primary first-line defense is a saturated solution of potassium iodide, which is often abbreviated as SSKI. Now, while we don't fully understand its precise mechanism of action against this specific fungus, it is remarkably effective for cutaneous and subcutaneous lesions. But you have to monitor your patient closely. If they develop iodide toxicity, which classically presents with a brassy, metallic taste in their mouth, severe burning of the oral mucosa, or sudden salivary gland swelling, or if they have a known iodine allergy, you've got to pivot immediately. In those cases, systemic antifungal agents become your alternative. Specifically, drugs like itraconazole are heavily utilized today. Meanwhile, older azoles like ketoconazole serve as a backup, though the literature does note that ketoconazole has more limited success compared to potassium iodide. Definitely know this pharmacological hierarchy for your exams. Fortunately, we can end this clinical review on a really high note. Patients diagnosed with sporotrichosis generally respond exceptionally well to treatment. Assuming they aren't severely immunocompromised with disseminated systemic spread, and assuming you catch the infection early and prescribe the correct antifungal regimen, you can confidently reassure your patient. They're going to heal up with very little, if any, lasting morbidity. Understanding that leap from a minor rose thorn prick to a chronic, indurated oral ulcer and being able to spot that incredibly tricky pseudoepitheliomatous hyperplasia is exactly what's going to set you apart as an exceptional clinician. It is quite literally the difference between a panicked cancer referral and a simple course of antifungals. But it leaves us with a critical question for your very next patient. When you're faced with a chronic oral ulcer that absolutely refuses to heal, are you ready to look past the obvious and consider the fungi hiding in plain sight? Think about it. To ensure you can instantly recall these crucial pathological mechanisms on exam day, be sure to subscribe to my YouTube channel, Master Oral Pathology, for more focused, high-yield learning. Keep studying hard, and I'll catch you in the next session.